Good morning. I'm Dr. Ashi Vijayaraghavan, Assistant Professor, Department of Pathology. Today, I'm going to take out a topic, lymphoma. So what is lymphoma? Lymphoma is nothing but a neoplasm of lymphoid tissue. So now, my question is whether it is a benign or malignant neoplasm. Since the term comes with the suffix "oma," we should not be misguided that it is a benign neoplasm. Actually, this is a misnomer, like seminoma, melanoma, glioma, which are all malignant tumors. This lymphoma is also a malignant neoplasm. Lymphoma is a malignant neoplasm which originate primarily from lymphoid tissue like lymph node, spleen, etc. The lymphomas are basically classified into two types. So the basis on which it is classified is the malignant cell or the immunophenotype of the malignant cell in the lymph node. So there is a characteristic neoplastic cell called as RS cells or Reed-Sternberg cell. So based on the presence of that malignant cell, which is the Reed-Sternberg cell, the lymphoma is classified into Hodgkin lymphoma and non-Hodgkin lymphoma. Today we are going to deal with Hodgkin lymphoma. So before going into the topic proper, I would like to share some details about the past of this disease. This name, Hodgkin's, was named after a British physician, Thomas Hodgkin. So way back in 1832, Dr. Thomas Hodgkin, who was a pathologist, he had done many postmortem. So based on the findings done of the postmortem done in 7 patients, he recognized or described a disease that is on the gross findings which he made out. So he described a disease in patients who are having enlarged lymph node. And when he went through the clinical history of these patients, he found that the disease had spread to contiguous lymph nodes or lymph node groups in an orderly manner. And the splenic involvement in these cases was a late development. He also found that in some of these patients, there were tuberculosis also. But grossly, when he examined the lymph node, the firmness and size of the nodes made him conclude that these findings are different from that of TB. But he didn't have any microscopic findings. His findings were everything gross, on gross examination. These observations were put as a research paper called Morbid Appearances of the Absorbent Glands and Spleen in the 1832. Later, in 1898, Dr. Carl Sternberg, who was a pathologist, he found that in microscopically there are typical giant cells seen in this condition. But he also couldn't conclude whether it is an inflammatory process or a neoplastic process. But he found that there is a typical giant cells seen in this disease. And later in 1908, Dr. Dorothy Reed, she could clearly illustrate that these giant cells, and also she could distinguish the Hodgkin disease from tuberculosis. In late 20th century, the Hodgkin disease was officially renamed as Hodgkin lymphoma. Hodgkin lymphoma accounts for 7% of all new cancers in the United States. And it was found that the average age at diagnosis is 32 years. Hodgkin lymphoma appears to be one of the most common cancers of young adults and adolescents, but also occurs in aged. This is the first human cancer to be successfully treated with radiation and chemotherapy, and it appeared curable in most of the cases. So WHO recognizes the following classification of Hodgkin lymphoma. So as per the WHO classification, there are 5 types of Hodgkin lymphoma, which includes nodular sclerosis, mixed cellularity Hodgkin's lymphoma, lymphocyte-rich Hodgkin lymphoma, and lymphocyte-depleted Hodgkin lymphoma, and nodular lymphocyte predominant. The first 4 ones are classified as the classical type Hodgkin lymphoma, since the Reed-Steinberg cell found in the first 4 types had a specific immunophenotype, which was different from the immunophenotype of the Reed-Steinberg cell found in the nodular lymphocyte predominant. So this classification of Hodgkin lymphoma into classical type and nodular lymphocyte predominant was based on the specific immunophenotype characteristic of the Reed-Steinberg cell present. So Reed-Steinberg cell, which is the neoplastic cell in Hodgkin lymphoma, forms the minor component of the tumor. So based on the molecular studies done on a single Reed-Steinberg cell, it was found that there is a clonal IGF gene rearrangement, which confirms that it is a neoplasm arising from the germinal center or post-germinal center basins. So since I told that Reed-Steinberg cell form the minor component of tumor, the major component, that is around 90% of the tumor, is composed of a robust mixed inflammatory cell infiltrate composed of non-neoplastic small lymphocytes, eosinophils, neutrophils, histiocytes, plasma cells, fibroblasts, and collagen fibers. So perhaps this is the only malignancy in which the tumor mass is not due to the number of malignancy, that is the RSLs, because this RSLs accounts only for the 1 to 2% of the infiltrate. Rather, the major component is the mixed inflammatory cell infiltrate. So moving on to the pathogenesis of Hodgkin's lymphoma, it was found that activation of NF-kappa B is found to be a major process in development of Hodgkin's lymphoma. Activation of NF-kappa B turns on the genes which promote the growth and survival of RSLs. And another observation made was that the latent membrane protein 1, which is a protein encoded by the EBV genome, transmits signals that upregulate NF-kappa B. So the conclusion made was that EBV infection is also a cause for Hodgkin's lymphoma. So we have already seen that there is a florid accumulation of reactive cells in tissues involved by Hodgkin lymphoma. So this robust inflammatory infiltrate is a response to a wide variety of cytokines and chemokines. So this is the proposed signals mediating crosstalk between Reed-Steinberg cells and surrounding normal cells in classic forms of Hodgkin lymphoma. Here we can see these are the different cytokines, interleukin 5, interleukin 10, MCSF, and chemokines like eotaxin, which plays a major role in the formation of this robust inflammatory infiltrate. So this forms the tumor microenvironment in which the neoplastic cells, that is the Reed-Steinberg cell, form the small component of tumor mass, and the inflammatory infiltrate, which is composed of predominantly eosinophils, neutrophils, plasma cells, macrophages, T lymphocytes, fibroblasts. They are the ones which support nourish and protect these Reed-Sternberg cells. So now, what is a Reed-Sternberg cell? So Reed-Sternberg cell is the neoplastic cell in Hodgkin lymphoma, which is described as a large cell of 15 to 45 micrometer in diameter with multiple nuclei or single nucleus with multiple nuclear lobes. And it has a large inclusion-like nucleolus, which is of the size of a small lymphocyte and has abundant eosinophilic cytoplasm. And this is surrounded by a clear zone. And this imparted owl-like appearance. So this is the typical Reed-Sternberg cell, which is a big cell having abundant eosinophilic cytoplasm and bilobe nucleus. And this is the nucleoli, inclusion-like nucleoli. And this imparts a typical owl-like appearance. So we will move on to the different types of Hodgkin lymphoma. To start with, we'll discuss the classical Hodgkin lymphoma. Nodular sclerosis Hodgkin lymphoma. This is the most common variant, and it is in 60 to 75% of the people. And when we discuss about the incidence, almost males and females have the same incidence. And this type of Hodgkin lymphoma predominantly involve the lower cervical, supraclavicular, mediastinal lymph nodes. It is most commonly seen in adolescents and young adults. And usually they present with an early stage disease and the prognosis is excellent. So when we talk about the morphology of the lymph node involved with nodular sclerosis, there will be abundant cells, which is the characteristic neoplastic cell, that is a Reed-Sternberg cell, is called as lacunar cell, which will have a folded or multilobate nuclei, and there will be abundant frequently disrupted pale cytoplasm, which looks like a lacuna. That's why it is called as lacunar cells. And locational RS cells, mixed inflammatory infiltrated node, also seen in the background. And there will be thick collagen bands separating these inflammatory infiltrate and the neoplastic cell, which gives an appearance of nodules. Hence, we have the name nodular sclerosis Hodgkin lymphoma. And this Hodgkin lymphoma is not associated with Epstein-Barr virus infection. So this is the histological picture wherein you can see this is a thick collagen band between this inflammatory infiltrate, giving it a nodular appearance. This is the hyperva showing the lacunar cell. It's multilobe nucleus with lacunae in the cytoplasm, giving the lacunar cell appearance. Moving on to the next variant, it is mixed cellularity Hodgkin lymphoma. This constitutes about 20 to 25% cases. This is the most common variant in patients above 50 years of age. The incidence is higher in males when compared to female. Usually, the patients with mixed cellularity Hodgkin lymphoma present with a disseminated disease or they present with systemic symptoms. That is, they present with a higher stage disease. Morphology, it is characterized by the presence of abundant RS cells and the mononuclear variant of RS cells with mixed inflammatory infiltrate. And in mixed cellularity Hodgkin lymphoma cases, 70% are associated with the Epstein-Barr virus infection. So this is the image showing the typical Reed-Sternberg cell, and with mixed inflammatory infiltrate, you can see an eosinophil here. And this is the multinucleated cell, and this is the mononucleated RS cells. And other two variants, that is the lymphocyte rich and the lymphocyte depleted, they are uncommon variants of the classic Hodgkin lymphoma. In lymphocyte rich, there will be frequent RS cells and mononuclear variant RS cells. And the characteristic feature is that there will be abundant T lymphocytes. 40% of the cases will be Epstein-Barr virus associated. And here, lymphocyte depleted, it accounts for only less than 5% of the cases. There will be frequent RSLs and mononuclear variant. And as the name tells, there will be sparse inflammatory infiltrate. And it is found that more than 90% of the cases will be associated with EBV infection. So moving on to the non-classical variant of the Hodgkin lymphoma, that is nodular lymphocyte predominant Hodgkin lymphoma. This is the rare variant account in only 5% of cases are seen. And the incidences, males have more incidence than female, and usually this is seen in younger age group, less than 35 years of age. Typically, they present with low-stage disease, that is, they usually present with an isolated cervical and maxillary lymphadenopathy, and they have an excellent prognosis. Here, 3 to 5% transform to high-grade lymphoma. So morphology, they have the typical RSL, which is called as the lymphocytic and histiocytic cells, or otherwise known as popcorn cells, with convoluted nuclei in large nodules. Along with that, we have small B cells and macrophages, rare eosinophils, plasma cells, and sometimes classic RSLs are also seen. As I told earlier, this differentiation into classic Hodgkin lymphoma and the non-classical nodular lymphocyte predominant Hodgkin lymphoma is based on the immunophenotype of the Reed-Sternberg cells. So in the classic Hodgkin lymphoma, the Reed-Sternberg cell is stain positive for the cluster differentiation marker CD15 and 30, whereas the popcorn cells, which are seen in the NLPHL, which is the non-classical variant of the Hodgkin lymphoma, the cluster differentiation markers 15 and 30 stains negative. They stain positive for CD20. And this NLPHL is not associated with Epstein-Barr virus infection. So this is the histopathological image of NLPHL. Here we can see there is the Reed-Sternberg cell seen in the NLPHL, which we call it as lymphohistiocytic type, or the popcorn cell, which is convoluted, like the nucleus appears convoluted, resembling the popcorn kernels, and hence the name popcorn cell. So this is the CD marker specific for NLPHL, that is CD20. Here we can see the RSLs are stain positive for CD20. So this is the tabular column from Robbins. This has put a nutshell on all the Hodgkin lymphoma. The first 4, nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depletion. These 4 types stain positive for CD15 and CD30, hence they are called as classic. And the NLPHL variant stain for negative for CD15 and 30, but it stains positive for CD20. This is the tabular column which we have to memorize. So once again, this is the typical RSL seen in the Hodgkin lymphoma. So moving on to the staging of Hodgkin lymphoma, this staging is called as Ann Arbor staging. Here there are 4, stage 1 to stage 4. In stage 1 disease, there will be single lymph node region involvement or single extra lymphatic organ or site involvement. In stage 2, there will be 2 or more lymph node regions on the same side of the diaphragm involved, or there will be localized involvement of an extra lymphatic organ or site. Stage 3, lymph node regions on both sides of diaphragm without or with localized involvement of extra lymphatic organ or site. In stage 4, diffuse involvement of 1 or more extra lymphatic organs or sites with or without lymphatic involvement. And further, it is based on the presence or absence of the systemic symptoms. It is classified as A or B. And symptoms are called as B symptoms, which include significant fever, night sweats, and unexplained loss of more than 10% of normal body weight. The typical clinical features of how the patient presents is that usually they present with a painless lymphadenopathy or with constitutional B symptoms. As I've already told, it is nothing but fever, night sweat, and weight loss. When the patient presents with a low stage disease, the cure rate is close to 90%. And we have already seen that most of the cases we can cure completely. There is radiotherapy, chemotherapy, and we have new treatment regimens. But the problem is that patients undergoing radiotherapy, they have increased subsequent risk of subsequent cancers. And when they with chemotherapy, there are increased risk of secondary tumors like acute myeloid leukemia. In people presenting with disseminated disease, the 5-year survival is found to be 60 to 70%, and they will have they commonly present with B symptoms, plus anemia or preventives. Now that we have learned Hodgkin lymphoma, this is the table from Robin summarizing the difference between Hodgkin lymphoma and non-Hodgkin lymphoma. So Hodgkin lymphoma is the lymphoma which is have the characteristic malignant cell, that is the red stem cell, and in this the disease is more often localized to a single axial group of nodes like cervical, mediastinal, or para-aortic. They orderly spread by contiguity, and the mesenteric nodes and the Van der ring are rarely involved. And extranodal involvement is usually uncommon, whereas in non-Hodgkin lymphoma, there is more frequent involvement of multiple lymph node groups, and there is no contiguous spread of neoplasm. The mesenteric nodes and Van der ring are commonly involved, and extranodal involvement is also common. So now we'll move on to the question and answer session. The first question is classification of Hodgkin lymphoma. So the Hodgkin lymphoma is classified into classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. And this classification is based on the specific immunophenotype of the RSL. And further, the classical Hodgkin lymphoma is divided into nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted, based on the morphology of the RS cells and the background inflammatory cells. Next question is the short note on RSL. So this is the typical RSL, which is large cell of diameter 15 to 45 micrometers with abundant eosinophilic cytoplasm. Usually, there will be multiple nucleus, bilobe. Sometimes it can be mononuclear also. There will be a prominent eosinophilic inclusion like nucleolus. And that will be surrounded by a clear zone, imparting an owl-like appearance. So when we describe, we have to describe about the variants of RSLs. So there are 5 variants. The first one is mononuclear, which is seen in mixed cellularity and lymphocyte-rich subtype. It will be a large cell with single round to oval nucleus with a prominent eosinophilic nucleoli. Second one is lacunar cell, which is characterized by a lobulated nuclei with prominent nucleoli and have a pale cytoplasm. The cytoplasm is often retracted and create a space surrounding it called as lacunae-like spaces. Third one is mummified cell. This cell has a condensed cytoplasm and a pycnotic nuclei. Fourth one is a pleomorphic RS cell, which is seen in lymphocyte depletion subtype. It has multiple irregular nuclei with prominent eosinophilic nucleoli. The last one is the lymphohistiocytic variant, which is seen in the lymphocyte predominant subtype. It has a small nuclei with lobulated nucleus, which resembles that of a popcorn kernel and also known as popcorn cell. The nucleoli is small, unlike the other variants. When we describe about the RSLs, there are one more type called as resembling that of the RSL, but we call it as RS cell-like. So cells resembling RS cells may be seen in infectious mononucleosis, solid tissue cancers, and large cell non-Hodgkin lymphomas. So now, how will we differentiate between RS-like cell and an RS cell? RS cells will be seen in a background of non-neoplastic inflammatory cells, and it will have a characteristic immunohistochemical profile. That is, in classical Hodgkin lymphoma, they will be CD15 and CD30 positive, and in NLPHL, it will be CD15 and 30 negative and CD20 positive. This is how we differentiate between an RS cell and RS-like cell. So now we have a case-based question. Here we have a 22-year-old female with fever, weight loss, night sweats, and painless enlargement of several supraclavicular lymph nodes. Biopsy from one of the enlarged lymph node is as shown below. The binucleate giant cell with prominent acidophilic eye nuclei shown did not stain positive for either CD15 or CD30 IHC. In which type of Hodgkin lymphoma are the malignant cell negative for? Answer is nodular lymphocyte predominant Hodgkin lymphoma. Moving on to the next question. Which is the virus associated with Hodgkin lymphoma? The virus associated with Hodgkin lymphoma is Epstein-Barr virus. So name the non-classic variant of Hodgkin lymphoma. It is nothing but nodular lymphocyte predominant Hodgkin lymphoma. So in which Hodgkin lymphoma, reactive lymphocytes form the majority of infiltrate? Reactive lymphocytes are seen as the majority of infiltrating lymphocyte-rich Hodgkin lymphoma. So next is which is the B cell marker expressed in lymphohistiocytic variant RSN. Lymphohistiocytic variant is seen in the non-classical Hodgkin lymphoma, which is the NLPHL, nodular lymphocyte predominant Hodgkin lymphoma, and these RS cells stain positive for CD20. So the CD markers positive in RS cells of classic Hodgkin lymphoma are CD15 and CD30. So now this is the last question. So name the B cell transcription factor that is positive in Reed-Sternberg's cells. Here they are asking about the B cell transcription factor, not the IHC or CD marker. So B cell transcription factor is PAX5. So we have completed the topic Hodgkin lymphoma. To summarize, lymphomas are malignant neoplasms classified into Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma is further classified into 5. Further subclassified into classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Under the classical Hodgkin lymphoma, we have 4 types. And the characteristic cell seen in Hodgkin lymphoma is the Reed-Sternberg cell. And Reed-Sternberg cell, they are of 5 types. And the immunophenotype, based on the immunophenotype of the Reed-Sternberg cells, we classify Hodgkin's into classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin's lymphoma. So I'm concluding the topic here. Thank you.